So good evening to one and all present over here on behalf of BSV. So I would like to introduce Dr. Yazhini Selvaraj. So former assistant professor of gynecology department, Madurai Medical College, and also the managing director and chief consultant gynecologist, IVF specialist of Ponni Fertility and Research Center, Madurai. And doctor is also a life member of IFS, ISAR, MOX, Indian Menopause Society, PCOA Society, as well as Endometriosis Society. Doctor is also a member of IFFS, ISHRE, and ASRM. So doctor has done more than 400 presentations in both national and international conferences, and doctor has received many awards, and most special awards are Amazing Woman Award as a woman entrepreneur, and Bharat Ratna Dr. APJ Abdul Kalam Excellence Award, and Mayan Awards 2018 at Malaysia, and Best Clinical Paper Award in Pertuition 2019, and Certification of Achievement Award, World Congress on Human Placenta, Fetal Nutrition and Metabolism in Las Vegas, USA. So, ma'am, now I'm handing over the session to you. So it's over to you, ma'am. So once again, thank you for giving us an opportunity for this session. Thank you, ma'am.
That's great.
Ma'am, the session is over to you, ma'am.
Good evening all. I bring greetings from Pune Hospital and Fertility Research Center. And thank you so much for your kind words. At the outset, I'd like to thank the organizers, the Bharat Serum Vaccines, for giving me this opportunity to deliver two speeches today. That is, one is RH Iso-Immunization. It's a sensitizing event. The other one is about Carbetocin, the newer oxytocin analog in the management of prevention of PPH. First topic is RH Iso-Immunization. And we all know that 15% of our population are RH negative and 85% are RH positive. So what is RH Iso-Immunization? There is production of immune antibodies in an individual in response to an antigen derived from another individual of the same species. And let me tell what is RH incompatibility. That is when a RH negative woman is carrying an RH positive baby, the mother will be having RH negative blood and the baby will be having an RH positive blood. So that is considered to be as RH incompatibility. And what is RH Iso-Immunization? When the mother starts producing antibodies against the fetal RBCs that enter through fetal maternal bleed. That is known as RH Iso-Immunization. The iso-immunization occurs in two stages. One is sensitization, the other one is immunization. Sensitization occurs due to antibody production in women with RH negative blood having RH positive fetus in utero. And immunization occurs when RH positive fetus blood leaks across the placental barrier and enters the next blood stream that can occur as a result of mismatched blood transfusion also. So here the RH positive man marrying an RH negative woman, and when the woman conceives, if the baby is RH positive, then the negative mother will be carrying her first RH positive fetus, and the antigen from the fetus can enter the mother's blood during pregnancy and also after delivery. So in response to the fetal RH antigen, the mother will start producing RH antibodies. Antibodies. So if the pregnant woman becomes pregnant for the next time, that is this second pregnancy, the RH positive RBCs that enter into her circulation, because her immune system had been already sensitized, her immune system will recognize that as a foreign antigen and will start producing a lot of antibodies, which will cross the placental barrier and that will destroy the red blood cells. The first produced antigen is M antigen, IgM, which is which has heavier molecular weight, and that will not cross the placental barrier. Whereas the second sensitization, the IgG is produced, which has a smaller molecular weight, and that will cross the placental barrier. Here, this is RH incompatibility. There is positive man negative woman with a fetus positive, and due to fetal maternal bleed, the RH mother gets sensitized to the anti-D antigen. Usually the first baby is safe and it survives because the antigen that is produced is only M. And during the second pregnancy, what happens? There is the repeat encounter with the fetal anti-D antigen and the rapid production of IgG antibodies by the mother, which crosses the placental barrier. It enters into the fetal circulation and it destroys the fetal red blood cells, thereby resulting in the hemolytic diseases of the newborn. In mild cases, it will be mild anemia and jaundice. And sorry, can the participants see this? Hello?
Ma'am, we can see, ma'am.
Yeah. And in severe cases, there is kernicterus and erythroblastosis fetalis will develop. So this is the first pregnancy where the mother gets first sensitized and she starts producing the IgM antibodies. And during the second pregnancy of same antigen positive, that is anti-D positive fetus, she starts producing IgG antibodies, which crosses the placental barrier and affects the fetal RBCs. So what are the causes and the risk factors that are responsible for the RH incompatibility or the exposure of the fetal RH positive blood? It may be during delivery, either vaginal or cesarean section, a threatened miscarriage or a miscarriage, trauma, external cephalic version, invasive procedures like chorion villus biopsy and amniocentesis, and ectopic pregnancies, molar pregnancies, antepartum hemorrhage like placenta previa, abruption, vasa previa, or uterine rupture, and non-fetal exposure to anti-RH positive blood like mismatched transfusions, bone marrow implantations, or needle stick injuries. So fetal maternal bleed, usually around 1 ml is occurring in 96% of women. That is considered to be the normal fetal maternal hemorrhage. But what happens in abnormal fetal maternal hemorrhage, about more than 30 ml of fetal blood will enter into the maternal circulation. And this occurs in around 1% of pregnancies. So during pregnancy, there is chances of 10% sensitization, and during delivery, there is 90% chances of sensitization. So 99.3% of women have a fetal maternal bleed, which is less than 4 ml. During first trimester, the sensitization is around 3%. During second trimester, the fetal maternal hemorrhage is around 12.1%. And during the third, it is 45.5%. And after delivery, it rises to 63.6%. And there is another entity called silent fetal maternal hemorrhage, where large volume of fetal maternal bleeds lead to severe neonatal anemia in the absence of obvious maternal symptoms and normal appearing placenta. It occurs at any gestation and can be fatal too. So this is the stages of pregnancy and the amount of fetal maternal hemorrhage, which corresponds to how much of volume, that is in ml. In first trimester, the fetal maternal hemorrhage may be around 6.7%, and the volume of fetal maternal bleed will be around 0.7 ml. In the second trimester, it is 13.9, and 0.8 ml will be the volume of bleed. And during third trimester, 29% fetal maternal hemorrhage can occur. The volume will be around 0.13. And during delivery, 76% of fetal maternal hemorrhage occurs, and the volume will be corresponding to 0.19 ml. So the risk of sensitizing also depends upon the quantum of the leak. The volume of fetal maternal hemorrhage, 0.1 ml, will have a risk of 1% sensitization, and 0.5 to 1 ml will have a 25% risk of sensitization, and more than 5 ml will have 65% of sensitization. So how to detect it? We have two tests. One is the Kleehard-Bidkis test, that is acid elution test, or flow cytometry, and the other one is the Rossetti test. So this detects around 2 ml of fetal blood, whole blood in the maternal circulation. You have to incubate the maternal blood sample with RH immunoglobulin, which will bind with the RHD positive red blood cells and will aggregate, leading on the rosette formation. That can be visualized by a single light microscopy. And in Kleehard-Betke test, we measure the amount of hemoglobin transferred from fetus to the mother, and the blood is mixed on a slide with, the maternal blood is fixed on a slide with ethanol 80% treated with the citrate phosphate buffer. After staining with hematoxylin and eosin, the fetal cells will be stained while the adult cells appear like ghosts. So the ratio between the fetal cells and the adult cells, that will help us to assess the amount of fetal-maternal bleed. So here comes the need for a postpartum prophylaxis. See, we all know the incidence of sensitization after delivery is around 12 to 16%. So if we give a postpartum prophylaxis with anti-D, then you can bring down the risk of iso-immunization to 1.5%. So postpartum prophylaxis of anti-D, which deliver anti-D positive, for the patient who deliver anti-D positive baby, either by a normal delivery or cesarean section, should receive 300 micrograms of anti-D within 72 hours of delivery in order to prevent the second baby getting affected. So here in 1997, Howard H. et al. Stated that provision of anti-D immunoglobulin was suboptimal in sensitizing events. In the second and third trimester events, more than 25% of patients in large maternity units and 33% of patients in small maternity unit did not receive anti-D immunoglobulin. And in 2000, it is a retrospective study where women presenting in the emergency departments prior to 12 weeks of gestation, 97 out of 112 were discharged without knowing the RH status. And in 2001, a survey study showed that 57% of cases of threatened miscarriage only received anti-D immunoglobulins. The rest didn't receive. So here, the essence of the antenatal prophylaxis. Why antenatal prophylaxis is very essential. This is to assess the amount of sensitization. You have to do the indirect Coombs test in the maternal blood. It can be done by 28th, 32 to 34 weeks of gestation. And if this indirect Coombs test is negative, then you have to consider giving an antenatal prophylaxis of anti-D 300 micrograms. It may be given at 28 weeks or 32 weeks, or even prior to delivery in order to prevent the RH allo-immunization by the fetal RBCs that occur more during the third trimester of pregnancy and also during delivery, which is expected to be more from the third to the postpartum period. So the anti-D prophylaxis in sensitizing events, an anti-D immunoglobulin is given to a woman to prevent her producing antibodies against RHD positive blood cells, thus preventing the development of hemolytic disease of the newborn. It is extracted from the plasma of donors having high circulating levels of anti-D. It is given usually intramuscularly and at the deltoid, and sometimes intravenously also, will prevent the sensitization during pregnancy and after childbirth. So the development of anti-D antibodies usually occurs as a result of fetal-maternal hemorrhage in an RH negative woman with an RH positive baby. So it has to be administered within 72 hours of the delivery or the potentially sensitizing event, and within 10 days may also provide some protection. I already told it has to be given in the deltoid muscle, and women who have already been sensitized should not receive this anti-D. So now we'll move on to seeing what are the potential events that causes this sensitization. During first trimester, when it is less than 12 weeks, you have the spontaneous miscarriage, threatened abortion, medical termination of pregnancy, surgical termination of pregnancy, ectopic pregnancy, vesicular mole, particularly if it is partial mole, chorion biopsy, and embryo reduction. In all these events, we have to give 50 micrograms, 50 to 100 micrograms of anti-D within 72 hours of the event. And during second trimester, when the gestation is more than 12 weeks, amniocentesis or abruptio placentae, blunt trauma, intrauterine death of the fetus, external cephalic version, and placenta previa with bleeding. For all these events, anti-D has to be given as 300 micrograms, and a test for the size of fetal metal should also be done. 10 micrograms additional dose of for every additional 0.5 ml of fetal RBCs in the maternal circulation is to be added. So now we'll move on to the guidelines and recommendations. According to the American College of Obstetrics and Gynecology, the unsensitized anti-D negative women should be offered prophylactic anti-D immune injections, that is within 72 hours of delivery if the infant is confirmed to be Rh positive. And the anti-D immunoglobulin is recommended for all invasive diagnostic procedures like chorion villus biopsies, amniocentesis, for all Rh negative, for all anti-D negative mothers who are having anti-D positive, who are having a Rh-D positive fetus. So the following recommendations are based on good and consistent scientific evidence. That is, the anti-D immunoglobulin prophylaxis should be considered for all Rh-D negative women, like threatened abortion, uterine evacuation, second or third trimester, antenatal bleeding, external cephalic version, abdominal trauma, and pregnancy termination, either medical or surgical, ectopic pregnancies, antepartum hemorrhage after 20 weeks of gestation, and suspected molar pregnancy, mostly the partial molar pregnancies. So the recommendations are for a complete miscarriage, 50 micrograms to 120 micrograms. If the gestation is less than 12 weeks and spontaneous complete miscarriage, there is no need for an anti-D before 12 weeks of gestation. But pregnancy termination, like medical or surgical, you have to give 50 to 120 micrograms if the gestation is less than 12 weeks, and 300 micrograms if it is more than 12 weeks. And for rupture tubal pregnancy, 50 to 120 micrograms up to 12 weeks of gestation, more than that, 300 micrograms. For chorion villus sampling, 50 to 120 micrograms if the gestation is before 12 weeks. And amniocentesis, 50 to 120 if it is before 12 weeks, and 125 micrograms to 300 micrograms after 12 weeks of gestation. Ectopic pregnancy, 50 micrograms is recommended. And for threatened miscarriage, if their bleeding is heavy also, you have to give 50 micrograms if the gestation is around 12 weeks. And the ICOG FOXI recommendations, it's aimed to prevent the sensitization during and after pregnancy. All patients undergoing MTP, medical or surgical, should have a knowledge of documentation of the blood group and Rh. After all sensitizing events in first trimester, 50 to 100 micrograms of anti-D injection has to be given. And for mid and late pregnancy sensitizing events and postpartum, the woman should be given 300 micrograms of anti-D. Due to lack of availability of the fetal-maternal hemorrhage volume testing, we can even administer higher doses to protect a majority of patients in high-risk situations. Now we'll see what are all the anti-D vaccines that are available: polyclonal, monoclonal, and recombinant anti-D. Conventionally, anti-D is produced via fractionation of IgG from the pooled plasma of Rh-D negative men immunized with Rh-D positive RBCs. The resultant IgG is polyclonal in nature and referred to as the polyclonal anti-D. And it is derived from the serum of immunized humans, made up of mixture of antibodies with affinity for a wide range of antigen epitopes. The limitations are the requirements for human donors, limited capacity of production, theoretical risk of transmission of viral and other diseases, and periodic shortages. Most of these limitations were addressed by the introduction of monoclonal antibody manufactured using the hybridoma technique. So the monoclonal antibody is highly specific antibodies against single antigenic epitope produced by the clone of a single hybrid cell formed in the laboratory by fusion. The commercial preparation is available in some countries. It is also available in India. The advantages are it is specific, consistent, uniform, safe from transmission of viruses and harmful proteins. The limitations are maintaining hybridoma in a stable culture is difficult, and generation of a monoclonal antibodies is a time-consuming, laborious process. Since the availability of growth supplements of hybridoma, such as fetal bovine serum, is declining, it further limits the possibility of increasing monoclonal antibody outputs. So here we compare the monoclonal with the polyclonal. Monoclonal has a greater and consistent efficacy when compared with polyclonal, and specificity is high. Half-life is 23 days, whereas polyclonal is 15.6 days. Purity, this is highly purified, and batch-to-batch variation is not much there, whereas it is there in polyclonal. The risk of transmission of virus diseases is there with polyclonal, and supply is unlimited supply with monoclonal, whereas there is shortage of supply with polyclonal. Now we'll see what is recombinant antibody. This is a natural successor of hybridoma-derived antibodies, and this recombinant recombinant DNA-derived antibodies, considering the advancements made in the technologies used for antibody manufacture. It is developed anti-IgG immunoglobulin using recombinant DNA technology and genes for antibody derived from the hybridoma to manufacture monoclonal anti-immunoglobulin. The antibody genes from this hybridoma were isolated and introduced in Chinese hamster ovarian cells, thus enabling the cells to express recombinant antibody. So the advantages of recombinant is always the need for fetal bovine serum, and it is obtained from serum-free medium, which quells the concerns of transmission of infectious diseases. It avoids problems of cell line changes and mutations as observed in hybridoma production shortage, and it also provides a better yield. The R antibody may be a suitable alternative to, that is a recombinant antibody may be a suitable alternative to existing antibody preparations in the market for the prevention of maternal allo-immunization, especially as the supply of human-sourced poly-antibody is expected to diminish. So to conclude, RH iso-immunization is a real problem, and real efforts need to be made to mitigate its impact. Although its incidence was decreased dramatically, yet the consequences of hemolytic disease of the newborn still remain. Every woman of childbearing age should have her ABO and RH types done at the first contact. Even today, a large number of women who should be protected against RH immunization are not receiving antibody. Despite postpartum anti-immunoglobulin prophylaxis, there is a risk of iso-immunization in RH negative mothers due to sensitizing events. The use of anti-immunoglobulin prophylaxis in sensitizing events has reduced the risk of iso-immunization further. The recommended dose of anti-immunoglobulin prophylaxis for sensitizing events depends upon the trimester at which these events have occurred. Now we will move on to Carbetocin, a new paradigm in PPH prevention. And these are the headings under which I am going to discuss. PPH, its introduction and epidemiology, the causes for PPH, the guidelines in the management of PPH, and we should know about what is Carbetocin, its pharmacology and other things, and some clinical studies to support its use. So what is postpartum hemorrhage? According to WHO, more than 500 ml of blood that is lost within 24 hours of vaginal birth, or more than 1000 ml of blood lost following a cesarean section is considered to be a PPH. And the ACOG defines PPH as blood loss greater than or equal to 1000 ml or blood loss accompanied by signs and symptoms of hypovolemia to be considered as PPH. And 60% of maternal deaths are due to PPH. And around 1,25,000 women die from obstetric hemorrhage every year. There are 5 major causes for maternal mortality: hemorrhage, unsafe abortion, obstructed labor, sepsis, and hypertensive disorders. And hemorrhage contributes the major share, that is around 38%. 35 to 56% of maternal deaths in India are due to PPH. What are the types of PPH? Primary and secondary. Any bleeding which occurs within the first 24 hours after delivery, following delivery, which affects the morbidity and mortality of the mother, is known as the primary PPH. And secondary PPH, any excessive bleeding from birth canal occurring between 24 hours to 12 weeks postnatally, that is after delivery. Here, the prevalence in India is 2 to 4% after vaginal delivery and 6% after cesarean section. Even a small blood loss that makes the woman hemodynamically unstable is also termed as PPH. Now we'll look into the etiology and the risk factors in PPH. There are 4 T's: tone, tissue, trauma, and thrombin. So tone is affected by uterine overdistension, uterine musculature fatigue, uterine infections, chorioamnionitis, uterine distortion, abnormalities, uterine relaxing drugs. And tissue, when the placenta is retained or the membranes are retained, and when there is incomplete placenta at delivery, that will also cause PPH, mostly the secondary PPH. And trauma, like cervical tear, vaginal tear, perineal tear, extended tear at cesarean sections, and uterine rupture, uterine inversion, thrombin, coagulopathies. So uterine atonicity is the most common cause for PPH. Around 50% of cases are affected by the uterine atonicity. Here, the atonic PPH, the risk factors and signs are prolonged use of oxytocin, high parity, chorioamnionitis, and general anesthesia. That will cause the atonic uterus. And overdistended uterus like twin gestation, multiple gestation, polyhydramnias, macrosomia, multiple myoma uterus, and uterine inversion that can be done by the mismanagement of 3rd stage or excessive umbilical cord traction and short umbilical cord or fundal implantation of placenta. Then other causes like genital tract trauma, episiotomy, cervical, vaginal, perineal lacerations, uterine rupture. The risk factors are the operative vaginal delivery or precipitous labor. And retained placental tissue can occur due to previous uterine surgery or incomplete placenta at delivery. And abnormalities of coagulation is seen in preeclampsia, severe infections, amniotic fluid embolism, therapeutic anticoagulation, those who are receiving, and abnormal bruising, fetal death, placental abruption, fever, sepsis, hemorrhage, and current thromboembolism treatment, those who are on current thromboembolism treatment. So blood loss can be estimated by weighing the compressors, visual estimates, collecting devices, and calculation of shock index. The severity of the condition can be estimated by the volume of the blood loss. If the volume is more than 500 ml, then the condition is called as abnormal. And if it is more than 1000 ml, we call that as severe PPH. If it is more than 2000 ml, it is massive hemorrhage. So what are the guidelines for the management of PPH? See, the Royal College of Obstetrics and Gynecology in 2016 said that a statistically significant reduction in the need for further uterotonics compared with oxytocin for those undergoing a cesarean, but not for vaginal delivery. No statistically significant differences between carbetocin and oxytocin in terms of risk of PPH. And the guidelines from the Canadian Society of Obstetrics and Gynecology recommend that carbetocin 100 micrograms given as an IV bolus over 1 minute should be used for the prevention of PPH in elective cesarean deliveries. This was the RCOG 2016 guidelines. And the use for an effective uterotonic for the prevention of PPH during the third stage of labor. And this was recommended for all births. We know that oxytocin, misoprostol, ergometrin, methyl ergometrin, and oxytocin and ergometrin fixed dose combinations were all used to control PPH. But the use of carbetocin, 100 micrograms IM or IV, is recommended for the prevention of PPH for all births in context where its cost is comparable to other effective uterotonics and vaginal birth or even after cesarean section. For PPH prevention only, we have to use carbetocin. This is ACOG 2017 guidelines where they recommend oxytocin. The dose and route may be IV, 10 to 40 units per 500 to 1000 ml of IV fluids as continuous infusions, or 10 units IM. Then if we use methyl ergometrin, IM 0.2 milligrams and can be repeated every 2 to 4 hours. If you use 15 methyl prostaglandin F2 alpha, the dose is 0.25 micrograms and milligrams, and intramyometrial or 0.25 intramyometrial can be also given. Every 15 to 90 minutes, we can repeat it. The maximum is 8 doses. And if you use misoprostol, 600 to 1000 micrograms, either oral, sublingual, or rectal can be used. And it's one time, the frequency is only once. Now, carbetocin is a longer acting analog of oxytocin with a similar mechanism of action and adverse effects profile. The increased duration of action of carbetocin compared with oxytocin eliminates the requirement for an infusion after the initial dose. It may therefore become the preferred first-line drug rather than oxytocin. And if we go to 2021, and ICM strongly recommend use of uterotonics during active management of third stage of labor to prevent PPH during vaginal birth or cesarean section. The recommendations are aligned with those made in the WHO 2018 recommendations on uterotonics for prevention of postpartum hemorrhage. So these are all the recommendations for prevention of PPH. As a prophylactic dose, oxytocin, first-line prophylaxis, 10 internationals per ml IM, or 5 internationals slow IV push within the first minute after delivery. And ergometrin or methyl ergometrin, 0.2 milligram IM within the first minute after delivery. And misoprostol, if oxytocin is not available or cannot be safely used, 600 micrograms orally within the first minute after delivery. PPH, for the treatment of PPH, either oxytocin, 10 internationals IM, or 5 internationals slowly IV push, or 20 to 40 internationals per liter as infusion. And misoprostol, 800 milligrams sublingually, 4 into 200 milligram tablets. Ergometrin or methyl ergometrin, 0.2 milligram IM, can repeat every 2 to 4 hours with a maximum of 5 doses for 24 hours period. And the symptometrin, a combination of oxytocin, 5 international units, and ergometrin, 0.5 milligrams. It's given in ampule, 1 ampule IM. Carbetocin, as I have already told, 100 micrograms IM or IV over 1 minute. And the carboprost, 0.25 milligrams IM every 15 minutes, maximum of 2 milligrams can be given. So, according to the Federation of Obstetrics and Gynecology of India, FOGSI, it recommends active management to prevent PPH in cesarean section. And oxytocin IV or IM is the recommended uterotonic drug for prevention of PPH in cesarean section. So here again, the same doses comes, but the action of oxytocin onset is by 2 to 3 minutes and it lasts for 15 to 20 minutes. Misoprostol, the onset is 3 to 5 minutes and peaks by 20 to 30 minutes and lasts for 75 minutes. And ergometrin, onset is 2 to 7 minutes. It lasts for 2 to 4 hours. Carboprust, 250 micrograms. Onset is 1 to 2 minutes and lasts for 15 to 20 minutes. So, according to the 62nd AICOG 2019 recommendations, the total duration of a single injection of intravenous Carbetocin on the uterine activity is about 1 hour. Hence, only a single dose is sufficient. Carbetocin has potent uterotonic effect on the pregnant and immediate postpartum uterus, and it has no effect on the non-gravid uterus. Its bioavailability is around 75 to 80%. Although oxytocin is the most widely used agent, there are several limitations which makes room for introduction of a newer agent. The limitations associated with oxytocin are, it has a short half-life, that is 3 to 17 minutes, and a continuous intravenous infusion is very much essential for that to maintain the uterotonic activity. And for elective cesarean section, a slow 0.3 to 1 international bolus of oxytocin over 1 minute, followed by an infusion of 5 to 10 international units per hour for 4 hours is required for women with PPH. And large doses of oxytocin is associated with adverse effects like hypotension, nausea, vomiting, dysrhythmias, ST changes, pulmonary edema, severe water intoxication with convulsions. So these limitations are targeted by the introduction of a new molecule, that is Carbetocin. So what is the mechanism of action? Carbetocin is a synthetic oxytocin analog that binds to the same myometrium receptors as oxytocin with similar affinity. It is a long-acting synthetic nanopeptide analog of oxytocin with agonist properties. Carbetocin selectively binds to oxytocin receptors present on the smooth musculature of the uterus, resulting in rhythmic contractions of the uterus with increased frequency of existing contractions and increased uterine tone. The half-life is around 40 minutes, which is 4 to 10 times longer than the oxytocin. Onset of contraction starts within 2 minutes, and the duration of action after single intravenous injection of Carbetocin will last for 1 hour. So the Society of Obstetrics and Gynecology of Canada recommends Carbetocin as the first choice of uterotonic agent to prevent PPH at elective cesarean section. Now we'll know about the pharmacokinetics. The concentration peaks in 20 to 30 minutes. The bioavailability is 80%. The distribution half-life of Carbetocin is 5.5 minutes, and it is eliminated by the non-renal route. And the elimination half-life is around 41 minutes. So the plasma half-life is 40 minutes, which is 4 to 5 times, 10 times longer than oxytocin. Onset starts in 2 minutes in 90% of patients. Act long enough to prevent postpartum hemorrhage in the immediate postpartum period. The duration of action after single intravenous injection of Carbetocin is 1 hour when given as IV and 2 hours when given as IM. The prolonged action compared to oxytocin attributed to the longer half-life of Carbetocin. So increase in the uterine tone, a reduction in the risk of PPH in elective cesarean section, where 1 dose of Carbetocin is equivalent to 16 hours of oxytocin infusion. So the indications and dosage, it is indicated for prevention of PPH due to uterine atonicity, and it can be used in cesarean sections under epidural or spinal anesthesia. Withdraw 1 ml of Carbetocin 100 micrograms and administer by intravenous injection under adequate medical supervision in a hospital. And for intravenous administration, which must be only administered after delivery of the infant or as soon as possible after delivery, and preferably before the delivery of the placenta. For intravenous administration, Carbetocin must be administered slowly over 1 minute. It is intended for a single use only. No further doses of Carbetocin should be administered. So the contraindications are during pregnancy or labor before delivery of the infant, it is absolutely contraindicated. and must not be used for induction of labor. And those who are hypersensitive to oxytocin should not receive Carbetocin. When the patient is having hepatic or renal disease or serious cardiovascular disorders or epilepsy, then Carbetocin is contraindicated. So what are the special population where we use this? Use during pregnancy prior to delivery of the infant is contraindicated. Breastfeeding feeding does not need to be restricted after the use of Carbetocin because it is secreted in small amounts in the breast milk and it is degraded by the enzymes in the gut. And pediatrics, that is less than 18 years, and geriatrics more than 65 years, it is not recommended. What are the drug interactions? No drug interactions have been identified with analgesics, spasmolytics, agents used for epidural or spinal anesthesia. Due to similarity with oxytocin, occurrence of interactions known to be associated with oxytocin cannot be excluded. Severe hypertension has been reported when oxytocin was given 3 to 4 hours following prophylactic administration of vasoconstrictor in conjunction with caudal block anesthesia. May also enhance the blood pressure, enhancing the effect of ergot alkaloids such as methyl ergometrin. Like oxytocin, Carbetocin's effect may be potentiated with prostaglandins. Some inhalation anesthetics such as halothane, cyclopropane may enhance the hypotensive effect and weaken the effect of Carbetocin on the uterus. Arrhythmias have been reported for oxytocin during concomitant use. So these are the summary of the adverse reactions like headache, tremor, hypotension, flushing, nausea, abdominal pain, vomiting, pruritus, anemia, dizziness, anxiety, tachycardia, chest pain, dyspnea, and metallic taste. Now we'll move on to the clinical studies that support the use of Carbetocin. And this was to analyze the effectiveness of Carbetocin compared to oxytocin for prevention of postpartum hemorrhage in cesarean sections. So there were 7 studies included in this. Most of the other studies which were non-randomized trials were excluded from this. And the outcome was analyzed where PPH and additional use of uterotonics and transfusion requirements. These are the outcomes that were analyzed. These are the 7 studies that were selected. And the conclusion was Carbetocin is effective in reducing the use of additional uterotonics. There was a reduction in the postpartum hemorrhage and that reduced the requirement for transfusions also. So this is yet another study where it was conducted by the Cochrane collaboration. A review was made in 12 randomized controlled trials involving 2,635 women to determine the effect of Carbetocin as against the conventional uterotonic agents for prevention of PPH. Here, 2 review authors independently assessed the trials for inclusion, assessed the risk of bias and extracted data. The primary outcomes were severe PPH, which was measured or clinically estimated blood loss of more than 1,000 ml or more, as defined by trial authors and irrespective of the mode of delivery. And the maternal deaths or severe morbidity like that required major surgeries, organ failure, intensive care unit admission, hyperparesia, or as defined by trial authors. So the inference was the risk of PPH was lower in the group receiving Carbetocin compared to the group receiving oxytocin. The risk ratio was 0.55. And here, this was to evaluate the efficacy of Carbetocin for prevention of postpartum hemorrhage. 30 randomized studies were taken into account, and they reduced the need for additional uterotonic use in women undergoing cesarean section and lesser risk in the postpartum blood transfusion in high-risk women undergoing cesarean section. So Carbetocin was found to be effective in reducing the need for additional uterotonic use and postpartum blood transfusion in women at increased risk of PPH undergoing cesarean section. This is another study where 5 RCTs with a total of 1,214 patients undergoing non-elective cesarean sections, where Carbetocin was compared with that of oxytocin. The primary outcome was the need for additional uterotonics, and the results were the need for additional uterotonics was reduced with Carbetocin compared with oxytocin. This is another study where the use of Carbetocin was compared with that of oxytocin in twin pregnancies. 166 twin pregnancies at term undergoing elective or emergency cesarean section were taken into account, and one group were receiving 100 micrograms of Carbetocin, and the other one was receiving oxytocin, 20 interaction units in 10 to 15 minutes. So the first group that used Carbetocin, where the fall of hemoglobin was very low, and the use of additional uterotonics in control of PPH was very, very low with the Carbetocin group. So Carbetocin was found to be more effective than oxytocin in preventing PPH in a population of twin pregnancies delivered by cesarean section. This is yet another study where 300 women undergoing normal vaginal delivery were consecutively enrolled and divided into two groups. One group was treated with Carbetocin 100 micrograms IV, and another group was treated with oxytocin 10 units IV. The postpartum hemorrhage was developed in 23 and 31 patients in Carbetocin and oxytocin groups respectively. And significantly higher number of patients were treated with balloon catheter in oxytocin group than Carbetocin. It is 77.4 against 39.1. And 13 patients in oxytocin group and 4 patients in Carbetocin group needed to treat in ICU. So Carbetocin is better than oxytocin in the management of third stage of labor to prevent PPH. Here, Carbetocin 100 micrograms given as an IV bolus over 1 minute should be used instead of continuous oxytocin infusion in elective cesarean section for prevention of PPH to decrease the need for therapeutic uterotonics. And for women delivering vaginally with one risk factor for PPH, like overdosage or something like that, Carbetocin 100 microgram IM decreases the need for uterine massage to prevent PPH when compared with continuous infusion of oxytocin. This was the inference gained by the Society of Obstetrics and Gynecology of Canada. And this is a retrospective and controlled before and after study in women with twin pregnancies that underwent cesarean section. The control group were 114 who received oxytocin or direct uterine injection, and the study group 127, which received 100 micrograms of IV Carbetocin. So the primary endpoint was change in hemoglobin. The secondary endpoint was risk of PPH and undiagnosed PPH, that is, the hemoglobin dropped more than 2 grams per deciliter, or blood loss or need for additional uterotonic maneuvers and blood transfusion. After adjusting for the confounding factors, the conclusion was the use of Carbetocin in addition to regular uterotonic agents decreased the total blood loss and also decreased the undiagnosed PPH. So to summarize all these studies, Carbetocin is effective in the management of third stage of labor in preventing postpartum hemorrhage in situations like elective cesarean section, emergency cesarean sections, in twin gestations, in women who are in high risk of PPH, and there is no need for additional use of uterotonics or blood transfusion. The blood loss also comparatively minimal with 100 micrograms of IV bolus of Carbetocin, which is given over 1 minute. So to summarize, Carbetocin is a long-acting synthetic oxytocin analog and also works by stimulating the uterus. The guidelines recommend Carbetocin 100 micrograms given as IV bolus over 1 minute for the management of PPH in elective cesarean deliveries. It has a longer half-life compared to oxytocin, and that makes it a choice. A single bolus dose is given to achieve sustained uterotonic activity, and it is effective in reducing the use of additional uterotonics. There is a reduction in the postpartum hemorrhage. There is a reduction in the need for transfusions after delivery when it is used during cesarean deliveries. So today's topic, the RH iso-immunization and PPH. So if we use anti-D, we can prevent RH iso-immunization in all sensitizing events. And if we use Carbetocin, we can prevent PPH and we can become a developed country in future. So an ounce of prevention is better than a pound of cure. Thank you so much for your patience listening. Questions are invited.
Ma'am, thank you for your wonderful presentation, ma'am. We can wait 1 or 2 minutes. So if there is any question arises now, then we can solve it, ma'am. Or else we can wait up.
Okay, okay. Do you have any questions in the question box?
No, ma'am, there is no questions, ma'am.
Shall we wind up?
Yes, ma'am. So, ma'am, once again, thank you for your wonderful presentation. The presentation was nice, and the way you explained was also nice, ma'am. Once again, thank you, ma'am, for your wonderful presentation for these two brands.
Thank you so much for giving me this opportunity. I thank the Board of Serum Vaccines for giving me this opportunity. Thank you so much.
Thank you, ma'am. Thank you.
Yeah, good night.
Good night, ma'am.